Hello, my name is Anna Claire, and my quality improvement project is about hospital-acquired pressure injuries. Critically ill patients develop hospital-acquired pressure injuries for a multitude of reasons, although I'm focusing my quality improvement project on two main things: prolonged vasopressor use in combination with inadequate pressure intervention given by nurses. It's a known thing that vasopressors can decrease circulation if they're given for a long period of time. This is first going to be seen in the extremities, your hands, your toes, as well as bony prominences. Vasopressors with decreased circulation lead to skin breakdown and the possibility for an altered skin integrity. Hospital-acquired pressure injuries, also known as this acronym HAPI or HAPI. You may be seeing that throughout this presentation, but they negatively impact not only patients, but the staff members such as nurses, aides, doctors, as well as the entire hospital organization as a whole. I want to spend a little bit of time discussing what are hospital-acquired pressure injuries. This is when the skin is broken down and pressure ulcers may occur, injuries to the skin, and it happens under the care of medical professionals. The picture shown on the screen shows common places where this breakdown can occur. I'm going to be focusing on ICU patients sitting at, let's say, a 30-degree angle. With this, there's going to be a lot of pressure in the sacrum and coccyx area and also the heels. I'm going to be focusing some of my new pressure injury prevention bundle on these two places. I also want to spend a good bit of time discussing the evidence of the problem and why it is in such need of improvement. To begin, in the United States, approximately 2.5 million acute care patients each year develop a hospital-acquired pressure injury during their stay. A 2019 article discussed that ICU patients who develop pressure injuries experience a greater risk of morbidity and mortality. This specific reference will be mentioned multiple times throughout my presentation. A 2021 study conducted determined that of the 122 ICU patients that were included in the study, those who developed pressure injuries were not repositioned as often as those who were repositioned. In the facility where the new quality improvement project is based, where my mentor works, her name is Wendy, and she is an ICU manager. Their fiscal year runs from September to October, and the last one, they had 6 hospital-acquired pressure injuries for a rate of 2.7. Hospital-acquired pressure injuries are known to cause psychological effects, which can also prolong healing. The 2019 study conducted determined that hospital-acquired pressure injuries in patients receiving vasopressors in high dosages was greatly more susceptible to receiving hospital-acquired pressure injuries than those in the low-dose categories. This is such a problem that the Joint Commission has now named this as one of their goals for the year. And lastly, a 2023 observation and descriptive study determined that using the Agency for Health Research and Quality calculator, they determined that hospital-acquired pressure injuries for 1,000 patient days decreased from 2.3 to 1.3. With this, there was an estimated nearly $4.8 million from that past fiscal year to the current one. Like I said in the beginning of this presentation, there's a multitude of reasons why hospital-acquired pressure injuries occur. I'm mainly focusing on two. Looking at this fishbone diagram, I show you how we get to those two. I first want to discuss staff. Staff members in the ICU, specifically nurses, are the ones who are at the forefront, who are implementing these pressure injury prevention bundles. And with the short staffing crisis that is affecting hospitals nationwide, these staff members are not having the opportunity to turn their patients as often as they should. Also, that every 2-hour turning, I will be mentioning in great detail throughout this presentation, but the Q2-hour turning is essential, and it is also commonly used in ICUs around the world. Medications that increase a patient's risk of developing a hospital-acquired pressure injury are, of course, the vasopressor and long-term use, as well as sedatives. When a patient is on a sedative for a long period of time, their ability to reposition and perform daily activities for themselves is greatly hindered. Thus, this also makes more responsibilities for the nurse to turn them, to feed them, reposition, all the things. Methods that can also incorporate to causes of hospital-acquired pressure injuries are going to be that the nurses sometimes have more pressing matters. It can be challenging for a nurse to think about repositioning their patient when they're trying to keep them alive. And I definitely understand that. This new pressure injury prevention bundle that I have developed that we'll be discussing can be incorporated without the nurse even knowing that they're incorporating this into their day. It shouldn't take away too much time and it should help them. Personal reasons why patients can develop a pressure injury during their hospital stay is going to be the severity of their diagnosis. Can they move themselves? Can they feed themselves? Are they cognitively aware? Nutritional status holds great deal of responsibility, and it's something that I think a lot of nurses kind of forget about. If a patient is super malnourished and they do not have a lot of muscle and skin protecting their bones, they are susceptible to skin breakdown. Comorbidities, including diabetes and peripheral vascular disease, are great risk factors for why patients can develop hospital-acquired pressure injuries, because that also goes hand in hand with that long-term vasopressor use and the way they decrease circulation in the extremities. Environmental factors that I would like to incorporate into causes would be a delay in cleaning incontinent patients. This new pressure injury prevention bundle that I have implemented is going to allow for nurses to monitor for incontinence and moisture control with the Q2-hour turning. Misuse of pressure injury prevention by staff is important to mention. I will be discussing ways to incorporate pressure injury prevention barriers, skin protective barriers in the new bundle. This is the current process the ICU uses in my quality improvement project. I first want to mention what the Braden scale is. You will see that throughout this flow chart. The Braden scale is a wonderful tool used to determine a patient's risk for developing a pressure injury. And in this flow chart, I really want to focus on that top box. It says, perform Braden risk scale assessment within 24 hours. The main thing that I would like to change, I think this risk assessment should be used immediately upon arrival in every shift. Also, I would like to add that in a 2020 study, over 12 months, 50 patients were included in the study, and it was determined that the Braden scale was 93.7% accurate. I would really like to incorporate this into my new pressure injury prevention bundle. Let's get into the topic of what my quality improvement project is going to look like. So aims for this project are going to be a strict Q2-hour turning, proper documentation in the EMR. This is essential because whenever we come back to look at data to see if this new bundle is working, we're going to look at nursing documentation. Implementation of turning clocks in each patient room. This is a great tool that I'm going to implement, and the image on the screen is kind of a loose idea of what that would look like. It's a great way for nurses to keep track of when they turn the patient last and where they turn the patient last. I find it pretty common that after 4 hours, you may have forgotten which side you turned your patient to, and this is a great way of keeping track to eliminate one side of the body getting more pressure than the other. Moisture control and protective skin barriers for all critically ill patients, regardless of their high risk or not, can they move themselves or not. All patients are going to receive skin protective barriers on their sacrum area as well as their heels. Staff compliance is a great aim that I wanted to include because I would love for the end goal to have more teamwork. The plan is going to take place over 12 months. Laminated flow charts, similar to the ones that we saw 2 slides back, will be included, except for that top right box will now say, do that risk assessment every shift and as soon as the patient's admitted to the unit. Turn clocks in all patient rooms. I also want to add that I incorporated the turning clocks for shift change too, because it can also, it's pretty common that nurses get caught up in shift change talking about the essential things that happen during the shift, and it can repositioning can definitely be put to the side whenever it comes to shift change report. So this is a way for, if it was missed during report, the nurse after shift change can go and look and see when that last turn was and where they need to turn them to next. Strict every 2-hour turning is essential to this plan. It's also going to be essential when it comes to measuring these outcomes. And like I said, the use of the Braden scale specifically. Measures for this quality improvement project. Every patient receiving vasopressors are going to be labeled high risk. High risk patients are going to need a little bit more attention when it comes to repositioning and pressure injury prevention. Also, I'd like to add the high risk group is going to include patients who are solely reliable upon hospital staff for daily activities and repositioning. Nurses will be implementing this pressure injury prevention bundle immediately, unlike the current process. Abide by that strict 2-hour turning, and I want the nurse manager to evaluate the staff compliance by conducting frequent rounding. The implementation will be immediately implemented. I have noticed that sometimes nurses can be hesitant to adopt a new process if it's expected to be implemented immediately and a goal to be established immediately. I want to allow for about a week or two for the nurses to adjust to this new process, and I want them to have the opportunity to give comments and give their opinions. I think it's very important whenever a process is going on. I want the staff, the nurse manager, to document the number of hospital-acquired pressure injuries monthly. And once that quarter comes to an end, they can tweak this new plan, add something to this new plan where they see fit. Goals for this quality improvement project. I want to decrease the number of hospital-acquired pressure injuries by at least half. I would love for it to be none, but I would go for 3. Improve patient outcomes, improve their experiences during their hospital stay, eliminate unnecessary hospital costs. As I said previously, hospitals are burdened by the cost of care when their patients develop hospital-acquired pressure injuries because the Centers for Medicaid and Medicare refuse to reimburse hospitals whenever patients develop these under their care. And I want to increase the nursing compliance with this new bundle and build teamwork and leadership. This is just a really simple graph showing how I would like these measurable outcomes to be. So as you can see, we started at 6 and I want to be at 3 by Q4. In conclusion, I'd just like to say that hospital-acquired pressure injuries are a major concern growing nationwide, especially for people in the ICU. These are significantly related to long-term use of vasopressors in combination with inadequate pressure injury prevention by hospital staff. Hospital-acquired pressure injuries impact not only the patients, but the staff and the facility as well. The implementation of the bundles into the quality improvement projects increases the chances of success and decreases the chances of failure. Immediate implementation of pressure injury prevention is essential in decreasing the occurrences of hospital-acquired pressure injuries in all ICUs. And these are my references, and I hope you enjoyed. Thank you.